So primarily what I want to talk about tonight um, is just kind of giving you my own perspective on issues surrounding suicidal ideation, uh, loss and suicide, um, anything having to do with that. And in my own mind, I separate it into three different parts. One is suicide prevention, one is um, suicidal intervention, and one is if there has been a suicide, how do we help individuals deal with the loss of a loved one? Um, because that runs into complicated grieving. Um, so suicide prevention takes a lot of different forms, but let me talk to you about basically the feeling of suicidal ideation. Um, so first of all, I think at some point in our lives, everybody thinks about, oh, I wish I wasn't alive. I wish I'd never been born. I wish I could escape this. And suicide may cross our minds. Everybody thinks about it, but they don't actually contemplate following through with it. And that's the big difference. A lot of times I've talked with clients and they say it really scared me when I that entered my mind and I thought about that. And so then we talk more about it and we process that. Um, Being mandated reporters as therapists, it's really important. This is like one of the most important subjects. Um, Not only so that no harm comes to our clients, but I never want to have a regret thinking, oh, how did I miss that? I wish I had done more. And so I've never personally had a client commit suicide or attempt suicide. Um, I have had patients from the hospital where I work uh, come back because they had, you know, attempted. Um, the But I will give you a personal story about something similar. Um, and the reason I'm sharing this story, it doesn't have so much to do with suicidal ideation or suicide, but really that feeling as a therapist, I just don't want to have any regrets. I don't want to question myself. Um, so, so in my very first counseling job, 1992, first counseling job, and I had a regular, a regular work day. I had clients, scheduled times to come in. But every now and then we would get an emergency, and I was asked if I could see a person um, who had schizophrenia and had had that diagnosis for a long time. And I agreed with the diagnosis. And they were on medication, but they stopped taking their medication and they could no longer stay at a group home because their behavior was erratic and it didn't meet the requirements of the group home. And so I saw them. Of course, if you ever have an emergency, it's probably at the end of a day when you want to go home and have dinner and de-stress and relax. And I think that part of who I was at that time, because I was a brand new counselor, I was really hyper vigilant, you know, because it was my first counseling job. I had just like graduated, and the most experience I had was internship. And so, I wanted to do everything right. I was one of my greatest fears. So my two greatest fears are, and the first one is not going to hurt anybody or cause any harm. It's running out of things to say in a counseling session when the client's not talking. Uh, because 50 minutes can be a long time if nobody's saying anything. And so I overcame that one. And but my second fear was I didn't want to miss something. I didn't want to cause any harm. I didn't want to say the wrong thing, but I also didn't want to miss something that I should have done, but I didn't. And so I was pretty hyper vigilant about making sure I did everything I could to help people. And I still am. I'm just not as stressed out about it now. And but so I stayed like 2 or 3 hours after the place closed. I lined up um, a relative that this person could stay with. I made sure that they had a appointment with a psychiatrist within a 24-hour period. Um, so I checked off all the safety boxes. They were not suicidal. They just had erratic behavior. Nobody was in danger. And but the hardest part was getting them in to see the psychiatrist within 24 hours. And because at that point I was living in a very rural place, and there weren't a lot of hospitals with psychiatric inpatient units nearby. Um, so they would have had to travel. And so everything came together. It worked out well. I had a release. I met with the psychiatrist and a treatment team, uh, on appropriate medication. Behavior became non erratic. Um, we were, and then so I continued seeing them until they could get with a permanent therapist. And so I saw them once a week for about 3 months, and things were going great. And then I didn't see them for a week or two, and I didn't know why. I reached out, tried to make contact, probably twice a week, and encouraged them to come back in. And then one night, I had just gotten home, and the police called me, and they asked me if so and so was my client. And I guess this person had once again stopped taking their medication for an extended period of time. And unfortunately, not a lot of police officers are trained well into how to de-escalate situations with individuals who have mental illness. And so he was acting erratically again. The relative with whom he was living called the police to help. And he felt threatened by the police. He held up a kitchen knife, and without de-escalating, they shot and killed him. I know that if they would have called me before entering the house, I could have simply talked with this person, de-escalated it, gotten him back on medication. Now they have services where many times mental health workers can go along on specific calls where an individual might be having a mental health crisis. But I mean, the way I found out was I said, yes, that's my client. Let me talk with him and I'll de escalate it. And they said, well, it's too late for that. So I immediately had an emotional reaction to this, of course, because I cared about every one of my clients. But the very next thing, and I couldn't sleep for, the rest of the night, um, was I wondered if I had missed something. My question was, could I have done more? Could I have done something differently? And so 1992, that's like almost 35 years of counseling. And fortunately, nothing like this has ever happened since then. But I saw my supervisor at work the very next day, and uh, they requested to see me. They were a great supervisor. And so first thing they asked how I was doing. And of course I said, well, I just want to make sure I had done everything I could have done that, you know, and I think that's a natural response. I think every therapist, anytime a tragedy happens, we might want to take responsibility for that, for missing something or not doing something we could have done. Everybody has those questions. If only I should have, or maybe I could have, or, something like that. But, so as soon as a tragedy occurs, the files are sealed. And then those files, like all the notes and everything, they go to lawyers and investigators, and they're reviewed. And so fortunately, uh, I got like a commendation. Wow, you really went out of your way and you did everything you could, which made me feel better, but the loss was still there, you know? So of course I saw supervision and some counseling just so that um, you know, I guess there was definitely some grieving with over my client, and um, even though it was definitely a professional relationship, I think we all care about our clients. But I think the one thing that really helped me through this loss was that I didn't have any regrets. And so my whole point about this is that individuals with suicidal ideation, you're going to meet them even more than people like the example I gave you. I don't want any of my students to ever have any regrets if something happens. I think that if you're in therapy long enough, if you're a therapist long enough, um, everybody's going to have some negative experiences. I don't know what they might be, but you're going to be seeing hundreds and hundreds of clients. And just by the sheer number of clients you encounter, if you look at a national average, somebody's going to have some tragedies, and and that's really unfortunate. But I want to make sure that students from this program do everything they can. So they won't have any regrets, so they won't question themselves. I mean, you're going to question yourself, but eventually not having regrets will help you move through this grieving process. This when we question ourselves. Um, because I mean, I can look back on it. I still wish there was something I could have done, but I could say now, but there wasn't anything I could have done. And that's the difference. Um, I think we come into contact with individuals with suicidal ideation quite often, more than the average person who's not becoming a therapist might imagine. And it also depends on what type of practice you're in. Like, I can honestly say, working at a hospital, 90% have some type of suicidal ideation. That's part of the criteria for going to an inpatient unit in a psychiatric unit at a hospital, other than, you know, psychosis. So as you move into practicum and clinical field, one of the things I think to become really familiar with is what are all the things that need to happen if you're dealing with somebody who is in crisis, who has suicidal ideation, who may be not taking their meds and in the midst of psychosis or some other danger. And, or, you know, if somebody, you know, is harm to self, others are in immediate, imminent danger themselves, you know, that limit of confidentiality. And, uh, and I think it's important to be prepared that if you encounter a situation and a client like this who is, you know, in danger, to kind of be able to throw your calendar out the window and stay until they're safe. And, you know, I have missed kids' birthdays. I have missed anniversaries, which is, you know, I've missed a lot of things because clients have needed help. And I never wanted to say that I had a regret or that I missed something or didn't do everything I could. So we're going to feel all of these normal life pressures. Uh, and yet you just have to be able to say, yeah, sorry, I just have to stay. And the other thing that I didn't have when I just started out was I didn't have a handy list of resources. I had all these resources that are open like, you know, 8 to 5, but I didn't have a list of resources that I could go to in this type of an emergency. So it's important to gather a broad list of research sources. What if you have somebody with suicidal ideation at the end of the day? What do you do if you have somebody who's experiencing psychosis at the end of the day? If you're in a metropolitan area, there's a lot more resources. You could simply call 911. There's a hospital nearby. But in rural areas or areas of, um, you know, that are struggling with socioeconomic growth or stability, they might not have the same amount of resources. And so you've got to have that list of people you can rely on or agencies that you can rely on when you're with somebody in crisis. So let's talk more about the specific topic of tonight, suicidal ideation. So I think, you know, there's a lot of prevention programs out there. Most of them are psychoeducational. And I think that's great. I think there's a place for that. Uh, but most of the time, prevention has to do with me talking with an individual one-on-one. And so they may not have a plan, they may not think about following through, but it's entered their mind and they're thinking about this. And it might scare them, it might be an option. My own belief about suicidal ideation is that most people don't want to die, even though they have suicidal ideation. The reason for suicidal ideation is that they want to escape severe emotional pain. and they've tried everything else. They've tried medication, they've tried supports, they've tried making life changes, and yet they don't see an escape from this severe emotional pain. And this is the only thing that they can think of that can give them that relief from this emotional pain, whatever the pain is that they're experiencing. And so, in most cases, when I talk with people that are contemplating this or have a plan or have tried to follow through and commit suicide, I think that I think most of it is just wanting to escape pain, and they don't know any other way. When we look at some of the national statistics with suicidal attempts and those who have committed suicide, the statistics are interesting. A lot more females, and I'm just going to use female and male because that's what the statistics are looking at. A lot more females attempt suicide than males, but a lot more males commit suicide. So how do you make sense of that? It's the way they attempt. So a lot of times, females attempt suicide with some type of overdose, whereas males attempt suicide with a gun. You can have your stomach pumped, you can't take that bullet back. And so it's the way people attempt that moves toward, I don't even like using the word successful suicide because I don't see it as a success, but you know. So that's the reason about those statistics. Let's see what else. So when we think about prevention, honestly, that there's a lot of psychoeducational programs out there that talk about prevention. But I think that that's great education, talking about it. That makes a difference. It really does. But I also think that two other things probably are important. First of all, is being able to talk with a therapist and getting that individual attention from another person who cares, who's present for them, who's willing to be present and to hear what they have to say, what they have to share, the pain that they're experiencing, and perhaps getting them to the resources, whether it's a better psychiatrist that is willing to get them down to a clinical baseline and get them off all their previous meds. Because what happens is people stack meds over years. Psychiatrists stack meds. And so if you have some condition that needs psychiatric medication, a lot of times they'll be taking one med and then it might not be working. So they add another med, and then they'll take away one and add another med. And over years, they never know what the actual baseline is. So when you have some severe diagnosis, and by severe, anything that impacts their daily life or includes suicidal ideation, the first thing I do is try to find a psychiatrist that'll work with them, and usually in a 14-day inpatient treatment program where they can gradually get them off their current medication that's not working and gradually put them on a medication that will work. Now, we're still in our infancy when it comes to psychiatric meds. We don't even know how some of them work. And we can't say, oh, this will be the right med for you. We just know categories. So we know, we know what types of meds might treat bipolar. We know what types of meds, antipsychotics, help schizophrenia. We know categories of meds, but we can't say this is the right med for you. So one of the problems with getting to a baseline and starting a new med is that it might take a week, maybe two, to get them to the baseline. It might take, I don't know, at least 7 to 14 days to see if a new med is working. But if it's not, you have to start over again with a different med. So sometimes, it might take 30 days to find the right med, but it's worth it. It really is. So I think the first thing is, finding a therapist and working with a psychiatrist who's willing to do this. Maybe they've never been on any medication. Maybe there's a need for it. And I know right now I'm stressing medication a lot, but with suicidal ideation, sometimes medication could save a life. I usually don't promote medication. I promote medication so I guess I don't promote medication with less severe diagnoses. But the more severe diagnoses, and like I said, by severe, something with suicidal ideation, something that impacts our ability to live on a day-to-day basis, um, you know, that's when I begin to consider it. And so I think that, and the other thing I want to say is sometimes medication can cause suicidal ideation. So one of the problems is that people see a number of different doctors. Okay, so they might see their family doctor, they might see a psychiatrist, and they might see a specialist for their heart and blood pressure. And a lot of times, these individuals are not in the same database. The only person who's got a database, a complete database on a person's medication, well, there's two, your insurance company and your pharmacy. And that's why pharmacists are so important in looking at the full list. Pharmacists are so overworked now, they rarely look at the list and they rely on the computer to tell them if there are incompatible medications. But I can't tell you how many times I've seen somebody for a psychiatric diagnosis where their physical medication, like heart medication or something like that, has interfered with their psychiatric medication and caused some really strange side effects. So we do have to look at that. The other medication that can cause suicidal ideation is if you look at teens, I would say teens to early adulthood, early 20s, some SSRIs can raise the risk of suicide. And so they even had to put a black box warning on some of the SSRIs. So there's a reason for that. So if you think about it, one of the things, so let's look at SSRIs. So we know that, a serotonin reuptake inhibitor. So what that does is it doesn't allow your brain to decrease the amount of serotonin it produces so that there's more serotonin or dopamine at one time in your brain, which elevates your mood. So, if you're experiencing depression or anxiety or something like that, serotonin and dopamine regulation may help with that. But let's say, you know, because of the reuptake inhibitor, it raises the amount of serotonin or dopamine in your brain and it elevates your mood, which is great. But another thing it elevates is impulsivity. And so it's the impulsivity that connects with suicide. So let's say somebody before an SSRI, and we're talking like, teens and young adults have a lot of impulsivity already. So when we think about it, if somebody is thinking about suicide, but there's a part of their brain that won't follow through with it, you know? So it's suicidal ideation with no plan to follow through, nothing like that. Then they start an SSRI because they're depressed or anxious or something like that. And it not only raises the serotonin or dopamine level in their brain and elevates their mood to get rid of the depression, but it also increases impulsivity and suicidal ideation is on their mind, but there was no follow through plan. But now we raise impulsivity, something happens in their lives, and that enters their mind again. But this time, there's no brake lever for that impulsivity. And sometimes they follow through on impulse. And if it's a male and they use a gun, then that's a permanent thing. So they put this warning on a lot of SSRI boxes, the black label warning. They've done a lot of studies since then because, the news was saying, oh, okay, well, maybe we shouldn't use SSRIs with this black label warning. But most of the studies say statistically that it helps many more people and that the statistical number of suicides that are connected with SSRIs is very low. And so now we recommend if you're a teen or young adult or have suicidal ideation at any age, that you should be monitored the first 2 weeks of taking an SSRI. And then that monitoring, if people take it seriously, that monitoring will significantly lower the possibility of suicidal ideation and impulsivity. Let's see what else. So let's talk about any questions about kind of prevention. Most people, when they talk about prevention, they talk about psychoeducational programs, and there's a lot out there. But I think it's more worthwhile to talk about these other things. Yeah.
How knowledgeable could you a student graduating from this program to be on medication?
So the question is, how knowledgeable should a student graduating from this program be on medications? All right, so I'm going to be honest with you. All right. Like, you got to go to an awful lot of school to be a psychiatrist,
Yeah.
you know? But I would say out of 300 primary medications in the field, most psychiatrists I know use under 100. And I would say anybody can become familiar with those to some degree.
Yeah.
So please do. I mean, so and by being knowledgeable about medication, I'm not saying you should be able to just prescribe or something like that. But I think it's good to know the categories of medication. This is for antipsychotics. This is for bipolar. This is for, whatever, depression, anxiety. I think you should know the categories of medication and what they're used for. But more importantly, what I found is you should know the side effects of the medications, because that's what you're going to notice in clients. So, for instance, when I was consulting with children and youth, they would bring a child into an appointment, and I would notice something, and like they would have a tic, and I'd say, "Oh, did you have that before you were on medication?" So if you have a 10-year-old child that has a tic and they're on Ritalin, their dosage is too high. And unfortunately, that tic can become permanent if the medication dosage isn't reduced. And there's some reason why that child is being dosed too high. So I would say, learn the categories, what medications are for what category, and learn the side effects. So let me tell you another side effect. So yesterday I was at the hospital, and one of the things I do, I check in with clients and I say, "Oh, can you tell me the emotion you're feeling right now? How are you feeling?" And on a scale of 1 to 10, Likert scale, 10 being good, 1 being horrible, where are you on that scale? And a woman described to me, so she had just been put on an SSRI 2 days, 3 days ago. And she said, "When I look in a mirror, I don't feel like it's me in my body." Definite side effect right there. Now, I know that this medication and this side effect can go away once the medication becomes balanced. But I'm still going to make a note of that for the psychiatrist to look at the dosage, the weight, how it's, being absorbed, things like that. So it's something to keep an eye on, you know. Yeah. So I think that's it. Yeah. Yeah.
So there are a couple states, I think there are 7 states right now where if you get a doctorate in psychology, then they can also take some classes in pharmacology. And then you're able to, as a therapist, prescribe some medication. What's your opinion?
So the question is, some states, if you get a doctorate in psychology and you've taken certain courses in psychopharmacology, they're going to let you prescribe. I would say absolutely not. Why?
I don't know. I saw a bunch of states doing it. I was like, this is weird because I saw pushback from psychiatrists saying that you're absolutely not educated enough at all.
Why would they say that?
I would say that's because it's a lot of, you make a lot of money doing it.
Okay, I got you. So you think psychiatrists are saying, "No, we don't want this to happen," because that's their money-making thing. Yeah.
It has something to do with them kind of, not that they're a middleman, but I feel like, I don't know, I feel like there's something else going on there too.
That's kind of city. That might be their specialty. So like, it would be like me coming in, studying an art therapy. She was like, "Here I am. I'm coming in as a clinical mental health person. I get certificates that say I can do some art therapy, but I'm not really
Right.
qualified to be in art therapy."
So it's not your specialty.
Yeah.
Yeah. Okay, so the answer is that in order to become a psychiatrist, you must first become an MD, a medical doctor. And the reason for that is because of all the side effects that psychiatric meds have. And most of those side effects are not only psychological, but physical. And so you have to be a medical doctor, in my personal opinion, or a psychiatric nurse, at least, to prescribe psychiatric meds, because so much of it affects physical well-being. It affects heart rate, it affects blood pressure, breathing. It's a long list of physical side effects as well. Yeah, yeah. And so, yeah, that's why it's so hard to be a psychiatrist. You got to be a medical doctor also. Yeah. Um, the so here's an interesting thing since we're on this tangent. Um, I would say that so many meds now that work were invented for something else, and it's the side effect that works. Yeah, that's the interesting thing.
Medication for like itching and it's, but now it's prescribed as like a panic attack medication.
Yeah,
Hydroxyzine.
yeah,
It was originally just for like people who had like rashes or itching on their skin, but now it's like pretty
Yeah.
common use.
yeah. What's the biggest example of this? So Ozempic's the new one. Ozempic. Okay, so Ozempic for diabetes, but actually that's kind of connected to what Ozempic does, which is basically lower cravings, make somebody feel full, but it really helps diabetes, can affect fatty liver, everything else. But that's the same category. Viagra, number one. So it's a blood pressure medication. Everybody talked about the side effects, and now that's what they're selling it for. Yeah.
I have another kind of niche example that I
Yeah.
didn't even know about until I was actually prescribed it. Um, the medication Lupron was originally created as a treatment for prostate cancer, but is now a super common medication used in the treatment of endometriosis, which is why I was prescribed it, was to treat endometriosis with. But it works in that it blocks certain hormone development, and they found that it also blocks like the hormones that endometriosis feeds off of, which is why it's a useful treatment for that as well.
Wow, that's interesting. Thanks. Yeah. All right. So let's talk about intervention. So when I say intervention, intervention is when, and just for the purpose of this lecture, because we've talked a little bit about prevention, but let's talk about intervention when intervention is intervening in somebody who is about to attempt suicide. Okay, so the classic example is somebody on a bridge, all right, or something like that. But it's more than contemplation. They're going to follow through with a plan. All right. Um, so so I used to take graduate students on mission trips every year where they could practice their skills. But I mean, I grew up in Chambersburg. I went to Shippensburg University. I had no world experience. I had never been out of the country. The furthest I'd been was to, like, I don't know, an army base in Georgia, maybe. So, I thought it was good multiculturally for people to get an experience outside of this country in another culture, but also to be able to practice their counseling skills. And every year we had a new experience. Like one time we worked with a woman's shelter and an orphanage in Peru. One time we worked with the elderly and an addictions facility in Puerto Rico. We worked with orphanages and lower socioeconomic, and by that I mean, like, cardboard houses in slums of South Africa. But one time we went and trained the police academy in Belize. And that was really interesting because we had to think about all of the different psychological situations that a police officer might find themselves in. And one of them was about de-escalating. One of them was about, you know, how to not use physical force. But one of them was about what do you do if you have to interact with somebody who is about to attempt suicide? And so I was doing all this research on it, and I started just reading stories. And there's a couple bridges in two different places in the world. Like one's in Asia and one's like someplace in Northern Europe, but they're pretty high bridges. There's a high number of suicides at these bridges. And all of a sudden, like I, about 20 years ago, the suicides almost stopped. And in both cases, it's for the same reason. Somebody moved into the house next to the bridge, and they would notice people not walking across the bridge, but standing in the middle of the bridge. And they were concerned the first time, and they knew that this was a place where people would attempt suicide. And so they would walk out and begin to talk with the individual. And so they did all of these interviews with individuals who were able to intervene successfully. And it amazed me because they had no psychological training. They had no training in how to prevent this or intervene. And they both did the exact same thing. And what they did was they would just walk out, they wouldn't get too close, and they would introduce themselves. Hi, I'm so-and-so. I live over there. How you doing? And of course, they would say, don't bother me, go away. And they wouldn't say what they were doing. And they would just start a normal conversation. Did you have a bad day? And as soon as they were able to start the conversation about anything, they would say, I live right there. Why don't we talk about this over tea? That was the line. And so, how do we apply these examples of something that seems so simple to suicide intervention when somebody is in the process of following through with their plan? And so I thought about this. And the first thing they did was not treat them any differently. They would treat them as another human being. They wouldn't say, don't move, don't jump. They would simply begin to interact with them. The second thing is they would be totally present for them. They would give them their attention. They would be kind, caring, empathic. They would listen when maybe this person has nobody else to share with. And then, rather than saying, okay, well, maybe don't jump today, they would say something totally different. Rather than saying what not to do, they would give them a positive alternative of something non-threatening to do. So they would say, well, let's go have a cup of tea and you can tell me about it. And so that gets them off the bridge. So it doesn't sound complicated, but I've tried this at the hospital. Nobody's attempting suicide at the hospital, but it's still in their mind. And so I've tried this same simple thing many times when talking with patients who were brought to the hospital for this reason. And, I think after a month or so when they left, I think the comment was basically, like they couldn't really pinpoint what it was, but they thanked me for talking with them like a human being and not a patient. And I think that's kind of what makes the difference. As soon as a professional, a police officer, a firefighter, a therapist comes into one of these situations, I think they automatically place that other individual in a new category. Patient, a person in crisis, and they begin to talk with them at a professional level, which is what they're taught to do. But I think you can talk with somebody professionally, but not lose that humanity, that connection, that human connection. And you can still talk with them about some serious stuff and not treat them like a patient. Uh, so, we read all of these journal articles about like being sane in insane places. That's probably the first one, where professionals are treating patients differently. It's almost like negating their humanity. And so to go in the total opposite direction and address them as another human being in a caring way and invite them to something more positive. And it's hard for me to explain this because it's not really, like a certain type of therapy, maybe I don't even know what we call it, but it's just what I found to work better, you know? And then once they're off the bridge, not in danger, whatever that might be, you know, then it's not only connecting them with services, it's not connecting them with doctors and psychiatrists and support groups. They need a human connection as well. Many people feel isolated, especially in today's society. Um, it's hard to make friends as an adult. And, but to reestablish that human connection, um, I would say that was probably one of the biggest deterrents. Now, obviously, other people have very specific issues where they're experiencing emotional pain. It could be abuse, it could be trauma, it could be rejection in a relationship, it could be grief and loss. There's 1,000 different reasons that would bring somebody to that point of emotional pain where they want to escape. And that has to be addressed in therapy. But I can tell you, one of the things they're feeling is isolated. Even if they're in a family, even if they're in some kind of group, they're feeling isolated. Like they can't connect with somebody about this. So let's talk about this. Any questions or comments about this? It's probably a different kind of perspective. All right, so let's just talk. We do have an entire grief and loss course, but let's talk a little bit about grief and loss, because when we're talking about loss due to suicide, I would say in almost every case, it leads to what we call complicated grieving. So in America, you know, we don't have a lot of empathy for grief. We think we do, but we really don't. We Our society expects people to get over things in a very short amount of time. And people say, is something wrong with me that I'm still grieving after 2 or 3 months? No, that's perfectly normal grieving. In fact, it's what we call the year of firsts. And people need to spend an entire year moving through birthdays, holidays, anniversaries, seasons, whatever happens during that year that happened with that loved one is now happening without the physical presence of that other individual. And so every time we experience something during that year of firsts, it's a shock to experience it without the other person present. And so that normal grieving goes on for at least a year. And I don't think we ever get over it. I think we change our relationship with that other individual. We integrate who that person was to us as part of ourselves. So I don't think we ever get over grieving. I don't think we're ever done grieving. I think our relationship with that other individual changes as a result of a healthy grieving process. But complicated grieving is when we get stuck in the process and we don't move through it. We don't move through the various stages of grief. We might get stuck in the concept of regrets. So I developed this theory, the regret theory, regret therapy. And there's 3 types of regrets. And it doesn't only have to be applied to grief at any part of our lives. But there's 2 past-related regrets. There's a regret of omission, things we omitted, things we did not do that we wish we had. I wish I had said I loved you more. I wish I had spent more time with you instead of working. There's a regret of commission, things we committed that we wish we hadn't, things we did that we wish we hadn't done. I wish I hadn't argued. I wish I hadn't said those hurtful things. I wish I hadn't worked so much. And then there's future-related regret. When we're with somebody in our lives, we plan a future with them. We might plan retirement. We might plan kids. We might just plan travel, whatever. But we have a plan, and that plan changes. And we're never going to be able to follow through with those plans by ourselves in the same way. And so what suicide does, it initiates complicated grieving, and we often get stuck in things like regret, or should I have done something different, or I wish I hadn't done that, commission and omission, or I'm never going to get to, future-related regret. And so there is an entire therapy on how to help people move through complicated grieving with suicide, but there's always some type of self-blame connected with it. And so that's what I believe that, we need to focus on. If somebody has lost a loved one due to suicide, it's not just suicide, but that's our topic for this evening. We have to figure out, where did people get stuck in the grieving process? Were people at a certain stage, anger, whatever it might be? And were regrets or personal self-questioning a part of getting stuck? And then we can move through kind of processing that regret. But I can tell you that it's one of the most difficult types of grief and loss for survivors, for sure. All right, that's our lecture on suicide. Questions, comments, anything you'd like to share? Go ahead, Hannah.
Thinking a little bit about suicidal ideation, but like in a session with someone and when they bring up things or if they joke about it, like at what point do you kind of like dive into that normal thinking, and then what point do you like kind of get concerned or cross that line where, okay, we need to like contact crisis?
Right, so the question is, if having a thought about suicide versus suicidal ideation versus a plan. As a therapist, when do we dive into that with all 3? Yeah, I always dive into it. And I try to figure out, it's just a passing thought. So anytime it's brought up, I dive into it.
And if they are just talking about it, but they're like, I really wouldn't do it, you wouldn't call crisis. or
No.
You wouldn't want to.
No,
Then they might not have got a call.
right. Yeah.
I don't know if you've ever experienced this, but I know there was like a phase where people were just like, oh my gosh, I'm gonna kill myself. Or they would just say that phrase almost all the time. And I remember hearing it one day at work about something, like they did something dumb. And it's like, I haven't heard somebody say that since I was like in middle or like high school. I can't remember. But it's like for a while, that's all I heard people would say. Or they would say KMS, which is short for, what I just said. So I just thought like, if you're hearing that, are we gonna like, should we do the same thing with him and like go right into it because we can never repeat this phrase?
So I remember that. You don't hear people, the question is, sometimes people just use the phrase, oh, I just feel like killing myself when something goes wrong, but they don't mean it. It's a phrase. So, if it's somebody in my life that I feel comfortable talking with and I don't want them saying that, I act concerned every single time. And they'll stop.
I have a technique question.
Yeah.
So when you have a client who is like mentioning suicide, but like is not planning it, usually the answer in all of my classes is just ask, are you making a plan? Is that still appropriate here? How do you kind of judge the level?
So if somebody is talking about some type of suicide, even if it just entered their mind, question is, how do you address that? Do you just ask, do you have a plan? So I don't just jump right to that.
Yeah, no, that was.
Yeah, but eventually I ask. In
Yeah.
fact, to be ethical, you must ask.
Mhm.
Yeah. But I mean, I go through, so I kind of lead up to it. I say, oh, well, tell me about that. What are your thoughts? And when they begin to, so I don't like act concern. I say, well, tell me a little bit more about those thoughts. And then it moves in one direction or another. And eventually, but every single time, even if it moves to, oh, it just crossed my mind and scared me, or yeah, I'm feeling really down and depressed and isolating. It doesn't matter. I always ask, do you have a plan?
You just phrase it, do you have a plan?
How'd you go about doing that? Isn't that a plan?
So much.
Yeah. But at the end, even if I phrase it like, how'd you go about doing that? Did you think about that?
It's still the
I'm
same
like,
question.
wow, that would hurt. But,
Mm.
but eventually I say, if they say no, then I say, so you don't have a plan or you do? I don't ask a leading question. I don't say, so you don't have a plan. They'll say no. I don't say, so I say, so do you have a plan? I don't want it to be a leading question.
Mm.
What else? All right. Have a good week, everybody.